Hi, everybody. So I have a quick question for you. How many folks in the room are pediatric neurologists? I know you two. Okay, a couple. And how many are adult providers, or mostly adult? Okay, great. So I'm Jennifer O'Malley, visiting from Stanford, and I'm really excited to chat with all of you about diagnostic process of how to recognize and come up with a differential for spells in kids. And we'll start off by finding the cursor. There we go. Okay, I don't have any disclosures for this talk. All of the patient videos that I'm going to share were very graciously shared with consent from the families, who I'm very grateful to. But nevertheless, please do not photograph or record any of the video portions of this presentation. So I want you all to imagine that you're in child neurology clinic. For some of you, that may be part of your daily routine anyway, but it seems like for many of you in the audience, it may have been a while since you've been to child neurology clinic. So just put that hat on, and your first patient of the day comes to you as a new visit with the chief complaint of "my child has spells." Where do you start? As we've seen from our other speakers this afternoon, the differential when we're thinking about adults is huge. That's true for kids as well. And also, as neurologists, I think one thing we are very good at and appreciate is that history is key. And that is no different when we're thinking about refining a differential diagnosis for a child who comes into clinic with events of unknown etiology. So I thought I'd start off like any parent might in the 4 to 6 month wait to get into child neurology clinic. While they're worried about their child's spells, they may go to one of the most popular doctors, Dr. ChatGPT, and ask, "What is this?" So I thought I'd try it out and see what happened. And, I have to say, Dr. ChatGPT did an okay job of giving us an initial differential. But you can imagine as a parent, if you're looking at this list, you're seeing things like seizures, breath-holding spells, syncope, migraine, some things that maybe sound scary, some things that don't, and it can be really hard to know what to do next. Hopefully most of us in the room, we still have jobs because we're a little more refined than ChatGPT at this moment. But when I think about a kid who's coming in for evaluation of spells, one of the first things I want to know is how old are they? Because that helps me start to refine what could be a massive sort of array of possibilities into a slightly smaller list. So if they're a baby, we're thinking about maybe a number of benign spells, like breath holding, and some other things that could be more problematic. We'll go into that list a little bit more later. For toddlers, the same thing. You can see the list is quite similar to infants, but maybe has a few other things to consider. And then for teens, we start to get into sort of more of what we might expect on an adult differential, including epilepsy, migraine, syncope, psychogenic etiologies, and a number of other causes. Okay, so our objective today is number one, to recognize the key clinical features for the commonest of spells in children across ages. And number two, to establish a clinical approach for evaluating such spells in kids. So you ready? Let's start off by defining spells in children. And I thought this was sort of a good way to start because as a child neurologist, I get to have the best conversations with my patients on a regular basis. And when I was chatting up one of the kids as I was preparing this talk, I explained to him that I was traveling. And he said, "Why?" And I said, "Well, I get to go give a presentation." And he said, "Well, what's it about?" And I said, "Oh, well, it's about spells." His eyes became huge, and he reminded me to make sure that I didn't forget to pack my wand. So, when you look at the dictionary definition of spell, it's described as a state of enchantment, where we're not fully in control of our own actions. So keeping that in mind as we think about spells in a neurology context, we are thinking about events that are by definition, paroxysmal or intermittent. These are episodic occurrences. They can be highly variable. May last a few seconds, up to hours. The spells themselves within an individual may be very variable, or the spells between patients that you're seeing in any given day can be quite different from patient to patient. The spells for a particular individual could be very stereotyped or highly variable. They may occur with or without behavioral arrest or altered mental status. And oftentimes these spells catch someone's attention because there's either not enough or too much sound and or movement associated with it. Sometimes those are very abnormal movements, but often, especially in kids, they're quite normal movements that are happening in an abnormal way, either an abnormal time or an abnormal pattern or an abnormal or inappropriate context. So what we're going to do today is we're going to start by characterizing the spell. We're going to capture that spell, so we'll kind of do those things at the same time today. But when you're in the clinic, you're really trying to get that history, trying to understand how do we characterize the phenomenology of the spell, what's happening at home or at school, and then capturing the spell. So whether that's a smartphone video, which is great when the family comes prepared, whether that's provoking it in clinic, or maybe doing different diagnostic tests to capture it, such as EEG. And then that helps us determine if additional testing and or intervention is needed. So I think we've kind of gone through this a bit already, but in the pediatric clinic, our first thought when we see a chief complaint of spells is, okay, is this a seizure or something else? If there's one take-home point you take from this lecture today, is that the majority of spells in children are actually non-epileptic. And this is summarized really nicely in the paper shown here, where what they conclude is that for most of these spells, they're not seizures for children presenting for evaluation. And this was a retrospective chart review of nearly 1,500 kids who presented with spells. And so the majority are non-epileptic. ADHD was the most frequent final diagnosis in about half. And overall, ADHD and normal behaviors remain the most common final diagnoses for this large cohort of children. So even those of us in subspecialty neurology, where we encounter zebras every day, the old adage still holds true. When you hear hooves, think horses. So sometimes it's really hard to tell. You know, I'll show you some videos, and routine EEG with hyperventilation can be helpful, but a lot of times it takes a really careful history and really understanding and seeing what these actual episodes are. So we've heard about epileptic spells from Manisha. I'm going to focus mostly on non-epileptic spells and the ones that are really seen commonly in my movement disorders clinic, with at least one example in each age category. But, you know, watch out. You never know. There could be seizures hiding in the midst. So today we're going to focus on spells that are common, brief, and occurring in healthy kids who have normal exams and the absence of other neurologic problems. We aren't going to talk specifically about childhood epilepsies, sleep parasomnias, pathologic movement disorders such as primary dystonias, chorea, ataxia, although that is something I do love to talk about, or syncope. All right, so you're in neurology clinic, in child neurology clinic, and think about what are some of the key pieces of history that you would want to ask this family with their child. We already talked about starting off understanding how old is the kid. When did these spells start? What were the features? Were there any clear accompanying stressors? Are there any accompanying abnormalities on exam? Can you get the sense of whether these are provoked or unprovoked? And this can be a very challenging detail to really get from the family. I think a lot of times families don't recognize any clear provoking factors, but with continued conversation and creative questioning, sometimes you can discover that there are some provoking factors. Are these spells happening just in sleep, just when awake, or both? Is there behavioral arrest or altered mental status associated with them? Can the child identify any urge, suppressibility? Are these interruptible or distractible? Oftentimes with kids, the family is so worried, the parents are so terrified that this is happening to their child, that when it happens, they sort of freeze up themselves. So they haven't necessarily tried to interrupt the spell, they haven't necessarily tried to distract the child from the spell. So really helping talk the family through sort of maneuvers that would be safe and appropriate for them to do to help explore how the kid responds during one of these events can be really informative for you too. Asking about urge. How do you ask a 4-year-old about urge? So if you say to an average 4-year-old, do you have urge to do this movement? They're probably going to look at you and walk away. So you could ask, what does your body feel like when this happens? Does your body tell you you have to make that movement? Or why, sometimes I just ask kids, why do you do this? The answers you get can be really informative. So being creative about how you're talking to children and how you're asking questions, putting it in the context of fun and play and curiosity can get you a lot more information. You'll want to know, are these single or multiple phenomenon? Are there any accompanying neurologic symptoms or psychiatric symptoms? And is there any history of similar episodes? This question, typically the answer immediately is no, because families don't necessarily consider a prior episode that was maybe a little different as being the same. So digging here is especially helpful too. So you may have a kid who presents with tics, and they say, no, absolutely not. He's never had anything like this before because he has a blinking tic. You say, well, did he ever have sniffing when he didn't have a cold? Or did he ever have a lot of throat clearing and you didn't understand why? Or did he ever throw his arm out like this and you couldn't figure it out and it kind of just went away? And they might say, oh yeah, that happened 2 months ago. So additional key history that we really want to tune into when we're talking about pediatric spells includes a full birth history and developmental history. Not just understanding, are these kids meeting their milestones, but are they meeting them on time? And a good family history is also helpful. This is another key point in pediatrics. Oftentimes you'll say, anyone else in the family have these spells or have ever had these spells? And the answer is almost always no. And I would say in my practice, about 50% of the time, at the next visit, the family comes back and says, aha, we talked to grandma and auntie, and turns out we both have tics. We just didn't know it. So really contextualizing it for the family, explaining what you're looking for, talking to them about this might be something you never even noticed you had as a child, who can you talk to that you grew up with, can help you get that family history. And then it's also essential to screen for typical comorbidities for many of the benign types of spells that we see in kids. And that includes ADHD, anxiety, OCD, autism, and learning disabilities. When we're thinking about new spells, we want to think about changes in the child's environment, changes in their caregivers, their family structure, new jobs, or changes in who's staying home with the kids, any changes in school. Bullying is something that we always screen for in school-aged children. And really trying to get an understanding of how these spells are impacting the daily routine for the child and for the family. A great sleep history is always helpful because it really helps you understand when and how these spells are occurring. And of course, considering the possibility for other effects of other medications, toxins, or exposures. So we've already talked about how the majority of spells in children of all ages are benign, and that we really need to use clinical clues to distinguish pathologic spells from benign spells. And that some of what the most common etiologies that you might be thinking about will vary between age groups. So let's look at some of those common spells across ages. When we're looking at infants, some of the most common, typically mostly benign etiologies for spells in infants that you'll see include shuddering spells, benign sleep myoclonus, benign dystonias or myoclonus, benign paroxysmal torticollis, spasmus nutans, stereotypies, Sandifer syndrome, and self-stimulation. When we look at toddlers, it's a lot of the same diagnoses, but you start to see tics and stereotypies emerging as a common diagnosis in this age group. There's also head nodding spells, breath holding, tantrums, and staring and inattention spells. In school-aged children, the most common differential sort of narrows, but includes tics and stereotypies, staring spells, and daydreaming. And in teens, we still see tics and stereotypies, and then we start to think also of FND. And I also put PKD and PNKD on here because the paroxysmal dyskinesias sort of straddle that line between, being benign and something we would intervene for. All right. So keys to examining spells in kids. Number one is you got to know your developmental milestones. It's really essential that you know what a 2-year-old should be doing or what a 4-year-old should be doing. And one of the things I think that we're really great at in both child and adult neurology is that we have exceptional observational exam skills. We really rely heavily on those in the pediatric clinic. It's amazing what you can get from a kid who doesn't know that you're watching versus a kid who you're directly sort of confronting for the first time you're meeting them and trying to get them to perform for you. So any chance you have, the exam really kind of starts in the waiting room. So any chance you have to peek out and kind of see how they're interacting with their family, how they're moving their body, how they're communicating, before you're actually the one trying to elicit that can be really helpful. It's also really beneficial to build engagement with the child deliberately. So one of the kind of things that we often do in child neurology clinic is we come into the room and we'll acknowledge the child. This is especially for young kids who might have stranger anxiety or are nervous. You acknowledge the kid, but then you really try to set a tone by talking with the family and letting the kid explore on their own. One of the things that can really break a child down is you come right up to them and start kind of aggressively engaging. You're very well intentioned, but they sort of shut down. So, if you're creative and methodical about thinking about letting the kid get comfortable in the space, the reason this is so important is you're going to get a much better exam. You have a much higher likelihood of getting the kid to participate and potentially demonstrating one of the spells of concern. All right, so let's move on to the most interesting part, which is the clinical video cases. So first, I'd like to thank all my patients who agreed to share their stories. And just a reminder, please no recording. And so each of these patients were sent to clinic to rule out seizures. So we'll start with our first patient. He's an 8-month-old who has a sudden onset of bilateral leg extension associated with staring and whole body freezing. The episodes are described as looking similar from episode to episode, but maybe with slight variability. The parents are engineers, they're really intelligent people, they're very good at documenting things. They bring you a lot of description and some videos. And the parents got really worried because they're noticing he's doing this thing that they describe as jackknifing, where he kind of like collapses into a jackknife position. And some maybe are interruptible. He seems to typically immediately return to whatever he was doing before when he's interrupted. And mom and dad are super worried about infantile spasms. They've read about infantile spasms, they've learned about it, and they're very, very worried. So here's the first video. And so, let's watch that one just one more time. If we can, let's see, let's start it again. So as I'm watching this, I see, a baby who's alert and interactive, but I do notice the extension of his legs with some pretty notable adduction at the thighs, which we call scissoring. Makes me kind of worried about his tone. The episode resolves suddenly, and he goes right to crawling. He has really nice head control, really nice appropriate movement of his arms and legs. So, this first video is, you're not sure. So we have more videos. The second video shows a little bit longer version of one of these episodes. We see that he's awake, he's looking at the person with the camera. At first it seems like maybe his arms are involved, but then mom says, "Can I have that sock?" And he reaches out to give it to her, and he goes right back to crawling. He has that beautiful head control, pushes himself nicely to a sit. He's appropriately annoyed for some reason. Pulls himself up to high knee position. So doing a lot of the things I want to see him doing at 8 months old. Here's another video of him lying on his side, again, with the legs extended and strongly cross-adducted. But you can see he's like appropriately using his hands. He's opening his hands nicely. He's transferring that bottle of lotion at some point between his hands. Sometimes the shaking is sort of semi-rhythmic. Sometimes it's clearly not rhythmic. Sometimes it's just in his hips. Sometimes it sort of migrates up to his torso. Mom calls his name. He looks over and smiles and goes back to his business. So on exam, you're probably noticing what we've talked about, his leg extension, the scissoring, some pelvic thrusting. You can't hear it, but not every time, but most of the time when this starts, he has some grunting. There's no clear behavioral arrest. He kind of seems like he's happy. He's maintaining his hand use throughout the episodes. The episodes themselves are a little bit different from time to time, although they have very similar features from episode to episode. They sort of change in what part of the body is maybe oscillating the most. There's this on-off phenomenon where they start and they stop, and he's right back to whatever he was doing previously. And there's no post-ictal period. So you're thinking in your head about what this might be. Any brave guesses out there? Yeah, infant gratification syndrome, exactly. So we see this all the time. It occurs in infancy to early childhood. And it often is coming in hot as a neurologic emergency because the family is terrified that their kid is having seizures. It can be described as whole body convulsions. Oftentimes the parents say we can't get it to stop, or it went on for minutes, and so it's very, very, very upsetting to the family. One of the great questions to ask on history is, where does this happen? Because it can often be provoked when the children are sitting in their car seat or in their high chair, especially the high chairs, which I pictured here, those that have like a post between the legs, or a car seat, a 5-point harness with a post between the legs. It often happens at times of diaper changing, or maybe when they're falling asleep, or other times where there's kind of self-soothing. And the clinical features, the reason I showed that video is a really nice example of typical features that you'll see with these episodes. So there's rocking and pelvic thrusting. There can be self-induced stimulation of the groin region. They may roll onto a toy to directly stimulate their groin. There can be a lot of dystonic posturing, grunting, and sweating is also common. And sometimes if you get just a little bit of the spell, you can see, like from that first video, you're wondering, does this kid have normal tone? His legs look pretty stiff and cross-adducted, but their exam as a rule is normal. And home videos are often essential in making this diagnosis. Many of these kids end up EEG'd, and that's okay, because the description can be very worrisome for seizure, but I think it's especially helpful if you can see them in clinic, and if you see a video where you can provoke one of these spells, you can feel confident when you have this type of history. And the mainstay of management is really reassurance, a lot of de-escalation, and normalizing this behavior for the family. A lot of families might be worried that there's someone abusing the child because they're demonstrating this behavior, and it's really reassuring the family that this is very normal behavior in this age, that it's not associated with as a sexual behavior in this age, that they're just doing something that feels good, and it helps them relax. So I find that I spend a lot of time just kind of helping take the blood pressure in the room down a few notches, which can be really helpful for families. So this is just one example. We only have 30 minutes, so I kind of have one example for each age group, but just some clinical pearls for where do you get worried when you're thinking of benign versus worrisome movements in a baby. Now, for anyone under the age of 1 year old, one of my mantras, if you talk to my peers and my trainees, is that you never trust a baby. So even though I showed you a really nice video of a totally benign episode, have a relatively high index of suspicion for seizures in any kid that's less than a year. If you're not totally reassured, go ahead and get that EEG. Make sure you're not missing something. With benign movements, there should be no evidence of delay, No evidence of encephalopathy, so this is, a baby who's not overly sleepy, a baby who's not crying all the time, a baby who's developing normally. There's a stereotyped presentation. There's typically no loss of consciousness. The events are interruptible. There's no alteration in mental status. There's no true behavioral arrest, and it fits with the phenotype of one of the known benign infantile movements. So, if you have a case that just doesn't quite fit, I would investigate, because you want to really make sure you don't miss something more serious. Okay, so your next patient of the clinic today is a 2-year-old, a typically developing kid who was premature and did suffer from neonatal abstinence syndrome. They also have night terrors and actually some benign nighttime movements. But they're presenting for new episodes of right leg repetitive jerking. These tend to happen when they're sitting on the couch or in the bed. They tend to happen when they're feeling kind of relaxed. They have had EEGs in the past, and it was not normal. They've had multifocal spikes on EEG in the past, but they've never had a clinical seizure. You can see it's getting a little more complicated. And so here is our patient.
And can you stop? Good. Can you make it happen? Make it go? And stop? Good. And was there another kind of movement? Let me see it. Do it again. And stop.
So on exam, you have a very adorable hyperactive toddler. This is the longest I got her to sit still ever. She's very able to follow instructions. Receptive and expressive language are intact. Despite her sort of prenatal history, she's been developing pretty well. And she's able to reproduce these episodes on command. And it was interesting when I saw her in clinic, because that was one of the first things I asked her. I was like, can you make it happen? And she did it, and her mom said, oh my gosh. I'm like, Mom kind of got it right away. So I'm not going to tell you much more about her. I'm going to move on to somebody in parallel. This is an 8-year-old child with complex repetitive movement of their lips that started suddenly after starting at a new school for the school year. So this is their video. Now, there's no audio on this video, but this child is really loquacious, super intelligent, and is describing to me this very dramatic story about how kids at school are interacting. Very, very descriptive. The parents are in the corner saying, we don't think any of this is true. And you may notice that, when he's talking, you don't necessarily see any abnormal facial movements, but when he pauses, that's when you really see this lip pursing and a little bit of a nose wiggle. And so these two kids have the same diagnosis, and anybody in the audience feel comfortable shouting it out? I see a child neurologist who knows the answer. So these are both tics. On your differential, though, you may also want to consider stereotypies. I always include on my differential for tics sunflower syndrome. So this is a self-induced photo-responsive epilepsy where kids will go to a bright beam of light and maybe wave their hand in front of their face to provoke seizures. It can look very much like a complex motor tic. You want to, especially with the lip pursing, you want to think about tardive dyskinesia. That's really going to be based on history. Are there any provoking factors that would lead you to think this could be a tardive dyskinesia? You know, think about episodic dyskinesias like PKD or PNKD, dystonias, chorea, all of these things, right, that are going through our heads with a broad differential for tics. But fortunately for both these children, these are benign motor tics. Tics are especially common. 1 in 5 or more school-age children will have tics, and 1 in 100 kids between the ages of 5 to 17 have tics. There's a mean age of onset between 4 and 8 years old, but you can see them quite a bit younger and quite a bit older. There's a preponderance in boys, but girls also have tics. The diagnostic vocabulary, I'm not going to belabor this, but the things you'll most commonly see are provisional tic disorder. This is if you've had tics for less than a year, or if you've had tics over a year and it's just motor or just vocal, that's going to be a chronic motor or chronic vocal tic disorder. And if you have both motor and vocal tics for more than a year in childhood, that's Tourette syndrome. I won't go through this chart in too much detail, but at the top, what I like is this distinguishes some of the features of the phenomenology of tics versus other movement disorders. So in tics, as a rule, there's an association with an urge, there's suppressibility, distractibility, and tics can occur both awake and during sleep. That sort of pattern really does distinguish them from other movement disorders like chorea, myoclonus, or dystonia. Oop, wrong way. So tics are sudden, rapid, recurrent, they're non-rhythmic motor movements or vocalizations. They can be simple or complex, and the movements, sounds, and postures are reproducible. They can be purposeful, non-purposeful, tonic or dystonic quality. Coprolalia, which is saying offensive things, or copropraxia, making offensive gestures, can be present in Tourette syndrome, but they're quite rare. There's also blocking tics, which are sort of these negative tics, or like a stop in movement. So these are kids who have sudden staring or freezing or posturing. Tics can really wax and wane. They come and go. The family's going to feel really frustrated because they'll say, when I made this appointment, this kid was like in status ticus. And then now a few months later, we finally get in to see you and he hasn't done it in a week. And you're really asking for that evidence of urge, suppressibility. And the other thing I just want to remind the crowd is that we really want to think about, when you have a kid with tics, to talk to them about the non-motor comorbidities. We know now that the outcome for children experiencing tics or Tourette syndrome is really predicted more by the severity and the way the comorbidities impact their lives rather than the tics themselves. So many of these children have anxiety, OCD, ADHD, depression, or learning disorders, and also screening for sleep problems. So addressing these problems when they exist in kids with tics can be just as essential to managing the tics as directly addressing the tics themselves. So when you're thinking about spells in young kids, again, this is just an example, but tics are the most common thing we'll see in this age demographic. Be creative when you're questioning about urge, suppressibility, provoking factors, and other important qualities of the episodes. Tics are really common. Most kids with tics aren't going to need medication, but look for those tic comorbidities that could be key drivers for the tics and may demand some extra attention and or treatment. Tic mimickers are rare, but you do want to consider the possibility of focal dystonia, and if there's any concern that this could be something like a photoparoxysmal, a photosensitive seizure, you'd want to get an EEG to rule that out. So our last demographic here are teenagers, and so I have a 17-year-old individual who has a history of Tourette syndrome since early childhood, and they present with a sudden onset of this new, very severe hand-shaking movement that is happening in the setting of the onset of the COVID-19 pandemic. Excuse me. Their chronic tic is this kind of complex head jerking. That stayed the same, but these new movements are really highly fluctuant. So here's the video.
You can just sit still. You can try to ignore me, but I know I'm right here up in your face, so it's kind of hard to ignore. And then you can just kind of let your...
So that kind of head jerk, that's their chronic tic. They're here because they're really concerned about this right hand movement. And so I want you to watch as we're talking together about this movement. You can see that it's kind of highly variable in the frequency, even the quality of the movement. The amplitude sort of changes. It stops and starts. When they focus on that hand, it can kind of get worse.
Yeah. And then arms up like this for me. Then arms all the way up. And put your hands down on your lap. And is there anything that you've noticed if you do it that will stop the hand shaking? Like if you concentrate on your hand.
I asked, is there anything that you do that will stop the movement? And they said, not really clear. And so then,
And then with your right hand, show me, or with your left hand, show me how you would brush your teeth.
so then I ask them to do specific tasks with their left hand. And what you'll notice,
I know, that's okay, just pretend.
I'll try to let you watch before I say anything.
How you would brush your teeth.
And you can notice what happens, the difference between when they use their left hand versus their right hand.
Okay. How about brushing your hair?
So you might notice that when they use their left hand and and they're distracted from focusing on the right hand rests and the movements stop.
And how about if you were...
When they use the right hand to do the same movement, the movements tend to worsen. So there's some fluctuation and distractibility. So this person has Tourette syndrome, but also has a functional movement disorder on top of it. And when we look at the risk factors or the positive diagnostic findings for functional neurologic disorder, they fit with many of these. So there's abrupt onset, sort of this maximum disability at onset. There's co-occurrence with other psychopathology, a widely variable phenomenology. And I think I'm out of time, but just a reminder, I think everyone in this room is on the same page. When you're diagnosing FND or FMD, functional movement disorder, we do this based on positive findings that support that diagnosis. So, the old school of thought was that this was sort of a diagnosis of exclusion. Of course, we need to be thinking with a broad differential and make sure we're not missing something, but there are key positive clinical exam findings that can make you feel confident in moving forward with this diagnosis. Some of the things that are demonstrated in this video, there's inconsistency, there's entrainment, there's suggestibility, distractibility, suppressibility. We kind of go right down the list here. All right, so last slide, pearls for spells in teens. You want to remember when you're thinking about some of the kinesiogenic or non-kinesiogenic dyskinesias, those are very stereotyped episodes. Seizures would be very stereotyped, kind of the same thing every time, whereas FND is going to have a lot more variability. If there's a sudden onset of maximally severe movements, that would raise your suspicion for FND. And in kids, mixed movement disorders are really common. So the presence of an existing neurologic problem increases your risk factor for a functional neurologic problem. And so, final take-homes, spells in kids are usually benign. Use your creative powers of observation to identify those positive findings on exam. The presence or absence of triggers, variability, and associated features can be key in narrowing your differential, and never trust a baby. Thank you, everybody, and I'll invite my panelists to join us up here for questions.